In hockey, lower limb injuries are the most common, and this is most commonly ankle sprains. The most common mechanism for the lateral ankle sprain is excessive inversion and plantar flexion. And grade 2 sprains is when there is tearing of the fibres of the ligament present and moderate instability, and there is pain and swelling present, which is moderate to severe. In hockey, at a professional level, there's normally 4 quarters. Sometimes it's 2 halves, but most we see 4 quarters. So here we've got the aims of the early phase. So we want to limit tissue damage, pain relief, control the inflammation stage of healing. We want to protect the joint, improve the pain-free range of motion and joint stiffness, and prevent muscle atrophy. So in this phase, we want to do police and avoid harm. So police, protect, optimal load, ice compression, elevation, and harm, heat, alcohol, running, and massage. So we basically want to avoid anything that's going to cause vasodilation and blood flow to the area. So we want to protect that end range and excessive range of motion, and that's our protect. Optimal loading depends on the clinical presentations, and use of crutches is often done for this. Ice reduces swelling edema by vasoconstriction. It's recommended 20 minutes every 2 hours for the first 48 to 72 hours in that early healing phase, or we can also do 10 minutes off, 10 minutes off, depending on the individual. Taping for that compression makes the area comfortable, and we want as much as on the skin as possible, and this minimises swelling by a pressure gradient. And elevation, lastly, we drain the swelling from the site, and it prevents pooling, and the aim is to keep the limb above pelvis and heart level. For the purpose of the photo, there's kinesiology tape, but for proper immobilisation it would be zinc oxide tape. So isometrics, according to this paper, they held for 5 to 10 seconds and did 7 reps per direction, 3 sets. So the therapist can do these and the client can do at home. So the therapist has a match my strength approach with dorsiflexion, plantarflexion, inversion, eversion, as seen in these photos, and the arrows are showing the direction of the force applied. The client can do, or the athlete can do eversion against a wall, inversion against the other foot, and then heel off the foot on top of the other foot for dorsiflexion, and plantar flexion can be against the floor. So to progress on the next phase, minimal or no pain with all given exercises so far, and a distinct muscle activation during the isometric contractions, and at least 50% of active range of motion in comparison with the non-injured side. In this phase of the programme, we have concentric exercises, then followed by eccentric exercises, pain permitting. We also incorporate more strength work into the programme and exercises given for homework, looking at lower body, upper body, core, proprioception, cardiovascular exercises. Everything that we do in this programme is pain permitting, so if the athlete feels any pain, we stop, reassess, see if we can regress them, and then we can always add in those exercises later on in the programme when they're pain-free. In this phase, we're looking at endurance strength, so around 3 to 4 sets at 12 to 15 reps, because the load is less, so we can increase the reps. So incorporating some strength interventions, we start with concentric exercises. So the weight of the resistance is against the movement. So we can do this as a therapist applying the resistance, or we can also do them with the band that the client can do themselves, which I've got in these photos. With the bandit, we can manipulate the resistance and the weight to make it harder, or regress it to make it easier. It is important to note that with concentric exercise with the band, there is some eccentric resistance that can't be controlled, so just monitoring that and making sure it's as small as possible. And of course, these all being pain tolerating and monitoring this. Eccentric, the resistance is into the movement and also against the movement in both directions, whereas concentric is just against the movement and then back to neutral. This paper states we could start with dorsiflexion and plantar flexion and then go into inversion, eversion. So for cardiovascular fitness, we do low impact activities on the joint and only allow this if it's pain free. So we can do battle ropes, arm cycling and swimming and water aerobics. Lower body exercises, calf raises. So we can start off with simple calf raises, then we can progress by adding dumbbells or kettlebells, increasing the weight and having heels off the surface to go lower. We can regress this by doing seated calf raises to take the weight and pressure off. So for core exercises, we can do a dead bug, and it's important to not let the back arch. If the back starts to arch, we'll need to regress. We can progress to toe taps, opposite sides, both arms, both legs, and progress by holding a weight. We can then do Russian twists, progress to weight as well, and it's important to breathe and keep core engaged. Then we can do a sit, lean back and diagonal, so breathe as you lean back, inhale as you sit up. And pain dependent, we can do 3 by 15. So as there's no injury to the upper body, we can look at more of an absolute strength rather than endurance, so increasing the load and then therefore decreasing the sets and reps. So looking at more of a 6 to 8 reps and 2 sets for the upper body. Similarly with the glutes, depending on the presentations and how the client feels, we can then go into absolute strength as well. So we can add in proprioception exercises, so a progression from a single leg balance is removing the visual cue and having eyes closed. And another progression is a therapist adding a distraction and then catching a ball. So to progress on the next phase, minimal or no pain with all given exercises so far and a distinct muscle activation during the isometric contractions and at least 50% of active range of motion in comparison with the non-injured side. So here we have the overview of the late stage in each component, and in this stage the aim is absolute strength. So with all the exercises given, it's going to be 2 to 3 sets and 6 to 8 reps. Obviously the lower the weight, the more reps we can do, and as we progress and increase the weight, we'll decrease the amount of sets and reps. So for strength and stability of the lower body, we've got an RDL. This can be progressed to increasing the weight and also making this single leg. It can be regressed by getting rid of the bar and just focusing on hip hinge. Reverse lunge can be progressed increasing the weight and regressed by removing the weight. Side lunge similarly can have more weight and then therefore less weight. A single leg hip thrust, we can add in weight as a progression here. Slanted angle stance on a single leg. This is adding in some challenging surfaces for that mechanism. And this can be progressed by doing calf raises, squats, RDLs, lunges. Can also be regressed by decreasing the angle of the slant, and this can also similarly be done with the band around the malleolus. Upper body now, so we've got a half kneel shoulder press with resistance band, and progression includes increasing the resistance of the band, using dumbbells instead, both arms simultaneously, and then finally incorporating a squat simultaneously. We then have a standing medicine ball swipe mimicking a hockey strike. We can progress this to standing on one leg like in the video. We can regress this by removing the medicine ball. And lastly, we have a medicine ball slam for the whole body and cardio. In this video, I'm not using medicine ball due to availability. I'm just mimicking the motion. All these So next we have some core exercises. So we have a pull-off press, and we can change the resistance band height and attach a hockey stick as well to imitate a slap pass. We can do a lunge twist and then progress this with a medicine ball throw against the wall. This imitates a twist when passing and core activation. And then lastly, we've got a dead bug with medicine ball between the knees, and we can change to holding this in the hands and the knees as well. We can progress this to both arm, both legs, and also straight legs. So next we have some core exercises. So moving on to some more challenging proprioception, we can add in the wobble board to the single leg balance. Progress this by having eyes closed and progressing this further by doing a pass and receive on the wobble board. And of course regressed by removing the wobble board. We can also do a side lunge to replicate the side movement seen a lot in the game. And lastly, the cone reach, there's 4 points, and reaching in front, side, posteriorly, and then to the side other way. And this can be progressed adding in a wobble board and making the points further away. So the first plyometrics drill we do is teaching the athlete how to land. So to do this, we would start with, as you can see in the video, up on the toes and then quickly coming down, dropping, making a loud noise with the heel of our foot and bending knees about 45 degrees to start with. We'd keep practicing that and we'd want the athlete to listen out for their heel hitting the floor. To progress this, we'd then make it deeper, and then when we add in a small jump, we then want the landing to be as soft and we don't want to hear anything, and then we can increase the height of jumping. Once we know the athlete can do this safely, we can then progress the plyometrics. We can also do an upper body medicine ball throw against the wall, which I'm demonstrating in the video, but for purposes I'm using a imaginary medicine ball as I didn't have one. We can do a gastrocnemius strength test and compare calf raises right to left, a range of motion assessment with a goniometer, power, so a hopping test, and also the star excursion balance test to test that ankle proprioception. So here we have the aims of the pre-discharge stage, and so we want to progression of speed, agility, advanced plyometrics, which are sport specific and getting the athlete back to their sport. So raise, we want to raise the heart rate and get the athlete nice and warm. Activate the muscles that we'll be using. Here I've got mostly lower leg work. Mobilise, so a lot of stretching out the muscles. Potentiate is more plyometric style, so lots of jumps and things like that. This can be progressed as we move through the programme. And regressing if need to. For the video, I'm just doing each exercise to once just for time purposes, but in a real sports scenario, it would obviously be lengthened to a more realistic time. Starting with linear speed, there's a 20-minute jog that can be progressed to a sprint when appropriate, and we know the athlete can perform it safely. Some progressions and regressions, so we can, across the 25-yard lines along the pitch, can do a jog and a sprint with different speed intensities across each line. Moving on to lateral, so we can do a shuffle. We can start doing a high shuffle and then progress this going high to low. Another progression we can do is having the band around the waist and sidestep accelerating and controlled deceleration. And then another progression we can remove the band and do pyramid runs, so running at different points and increasing the distance each time. Multi-directional, as seen in the video, making it more sports specific, so the athlete faces me when I shout a colour, turn around and run forward and side shuffle to that colour, run back to me, receive the ball, pass and move, and then do a backwards run to the starting point. Then another multi-directional one is a zigzag run, so on the forward, pass, receive, do a side shuffle, run back, and then run slightly diagonal forward, receive the ball and repeat, as shown in these videos. So the first agility drill being a T drill, so as demonstrated in this video, a progression can be on the backwards run back to the point, intercepting a pass left or right, so incorporating that side lunge movement that is often seen when reaching out to intercept a pass. A regression can be to not touch the cone and just focus on getting to the points. Next, we've got a ladder in an outside step, so really quick feet, and making this sport specific. Run left or right, receive a pass at the end, and then dribble it back to the start. We could also add in some cones to weave in and out on the run back as well. We want the athlete to be able to look up and not look down at their feet once they know they can do this safely. And a regression would be to perform this slowly to ensure they can get their feet round. So first thing, we'd make sure that the athlete can land safely, and then we would progress into some more advanced plyometrics in this pre-discharge stage. So we can do a squat, tuck, jump, scissor jump, skater jump, side to side bounds, hurdle hops, and we can progress this to single leg from double leg, and a drop jump. And we can progress and regress depending on pain and how the athlete progresses through those. So I have adapted these tests to progress criteria from a couple of papers researched, which I've stated on this slide. We wouldn't expect the athlete to return to a full game straight away. Working with the coach and the multidisciplinary team, coming up with a strategy, assuming they would be able to have a staggered return to play, so playing perhaps in the last quarter or the last 10 minutes of a game, and then building up from there and building up their stamina to ensure they are safely returning to the sport. And I'll continue to work with them until they are returned to a full game.